Good afternoon. My name is Claire Saxton with the Cancer Support Community. Welcome to our webinar, Frankly Speaking About Lung Cancer, What You Should Know, hosted by the Cancer Support Community. If you need technical assistance during the webinar, please dial 1-866-229-3239 and press option 1. Before we start, I'll go over some reminders and housekeeping items. If you would like to listen to today's presentation via telephone, please dial in using the conference line code you see on the screen. Today's call is being recorded and will be available on our website at www.cancersupportcommunity.org/webinars within the next week. The format of today's webinar will be as follows. The panelists will begin the discussion first, and then we will open the discussion up to the audience during the question and answer session. Thank you to those who submitted questions prior to the webinar as part of the registration form. If you would like to ask additional questions, feel free to type it into the Q&A box on the right of your screen. You may submit a question at any time during the event. At the end of this webinar, you will be automatically redirected to the post-webinar survey. Please take a few minutes to complete this survey as your input is of great value to us. I would now like to introduce the Cancer Support Community, which is the largest professionally led nonprofit network of cancer support worldwide. CSC is dedicated to ensuring that all people impacted by cancer are empowered by knowledge, strengthened by action, and sustained by community. We offer the highest quality social and emotional support through our local affiliate network, as well as online or over the phone. On this screen, you'll see some of the resources we provide at the Cancer Support Community. The first one there is the Cancer Support Helpline, which is staffed by licensed professional counselors who are available to assist you Monday through Friday, 9 a.m. to 9 p.m. Eastern Time. We also have our Open to Options program, which is a research-proven program that can help you prepare a list of questions to share with your doctor. We also have our Frankly Speaking About Cancer program, which is CSC's landmark education series that provides trusted information on a variety of topics important to people affected by cancer. Information is available through print and digital publications, online, and in-person programs. I would also like to introduce our Cancer Experience Registry, which is a unique project for people affected by cancer. People who have been diagnosed with cancer and those who help care for them can join the registry. You begin by answering survey questions. Your answers and those of others describe the experience of cancer patients and caregivers. This information is used to provide education and support resources that speak to patients, caregivers, and their needs. For more information or to join, visit www.cancerexperienceregistry.org. I would also like to take a moment to talk about our grassroots movement, which helps ensure that people touched by cancer have access to quality, comprehensive cancer care that includes social and emotional support. Again, if you'd like to learn more about this program or to sign up, visit our main website at www.cancersupportcommunity.org. I would now like to introduce today's two panelists, Dr. Seth Cohen and Dr. Debra Sullivan. Seth Cohen, MD, is a board-certified internal medicine physician and medical oncologist who specializes in breast, colorectal, and lung cancers, lymphomas, and genitourinary and gynecological malignancies. Dr. Cohen is a fellowship-trained in hematology and oncology with a subspecialty in pain and palliative care and has been practicing at Monmouth Hematology Oncology Associates since 2004. Debra Sullivan is a licensed clinical psychologist who received her master's and doctoral degrees from the Catholic University of America, where her focus was on resilience, the positive capacity of people to cope with strength and adversity. Dr. Sullivan has served as the program director of the Cancer Support Community East Tennessee for over 15 years. In her role, she provides direct clinical service to those impacted by cancer, including facilitating weekly support groups, supervising all clinical staff, and overseeing all educational and support service delivery. I'm now going to ask Dr. Cohen to talk to us about the types of lung cancer and the treatment options available. Dr. Cohen?
Thank you, Claire. And I want to thank the Cancer Support Community for sponsoring this event and for the sponsors of this event, and especially Claire for organizing it. Today we're going to be talking about lung cancer and what you should know. Lung cancer is the second most common cancer in both men and women, following both breast for women and prostate for men. There are two main categories for lung cancer. One is called non-small cell lung cancer, initialized as NSCLC, and another type of lung cancer is called small cell lung cancer, SCLC. Non-small cell lung cancer comprises approximately 80 to 85% of all lung cancers and has three major subtypes. Subtype number one is adenocarcinoma, which accounts for 40 to 50% of non-small cell lung cancers. Squamous cell carcinoma accounts for less than 30% of non-small cell lung cancers, and large cell carcinoma represents less than 10% of non-small cell lung cancers. Small cell lung cancers make up 15% of lung cancers in the United States. These are typically rapidly growing and aggressive, more so than non-small cell lung cancers. They are predominantly diagnosed in those who smoke and those who have previously smoked. About 98% of cases are attributed to smoking. In terms of lung cancer screening, lung cancer screening is recommended for high-risk groups using a CT, which is a computerized tomography scan. The U.S. Preventive Services Task Force recommends screening for people 55 to 80 who are of the following characteristics: those who currently smoke, previously smoked and have quit within the last 15 years, and have a history of 30 pack years. This work was actually a research study called ILCAP, which is the Early Lung Cancer Action Program, and it's an international study. In terms of choosing your healthcare team, communication style is important. You need a healthcare provider you can trust and who can answer your questions. Your healthcare team should be one that is readily available to you, provides emotional support, and excellent nursing care. You should feel respected and listened to. You should feel comfortable with your doctor's level of expertise. Your healthcare team should be multidisciplinary, including doctors, nurses, social workers, case managers, sometimes physical therapists, nutritionists. Getting a second opinion. And I'm quoting a patient, or a caregiver, I'm sorry. If I learned one thing, it's that when dealing with any chronic disease, you have to be your own best advocate. There were several times that we brought a second opinion to the table. We felt it was better to be armed with information and come with an opinion versus just sitting back and letting someone else make all the decisions. This was quoted by Meg, who's a lung cancer caregiver. Communicating with your healthcare team. You should always bring questions to your appointments. You should always write down things to help remember what the doctor says and what you don't remember. Bring a friend or relative to take notes and ask questions and provide you with support. You should always ask for copies of tests and results and ask for side effects and symptoms and any printed material that you can go home and look up later on. Tell your doctor about all your medications you're taking, and very important to include all vitamins and herbal supplements, as they as these medications may influence the medications that the doctor puts you on. Treatment options depend on the following things: stage and type of cancer. As we mentioned before, lung cancer has two predominant types, both small cell and non-small cell lung cancer. It's important to always take into consideration the general health at the time of diagnosis. The health history, i.e. other comorbidities that the patient might have, will influence the type of treatment a patient will get. And always before a treatment is defined, the goals of treatment need to be made aware for the patient, either in the curative setting or the palliative setting, meaning relieving the symptoms of the patient. Discussion of treatment options with experts in lung cancer include the following groups: a thoracic surgeon, that's a surgeon who does surgery on the lung cancer; a medical oncologist, who usually provides chemotherapy; a radiation oncologist, who provides radiation therapy; and a pulmonologist is a doctor who is essentially a lung doctor. There are various questions to ask and discuss with your doctor. Number one, which treatment do you recommend and why? What are the short and long-term side effects might I expect? How will I know if the treatment is working? Are clinical trials an option? What can I do to prepare for my treatment? Who do I contact if I have questions? What are the services that are available to me and my family? And finally, how do I help the managing costs of my cancer care? Now we're going to begin the stages of the cancer in non-small cell lung cancer and the treatment options. There are 4 stages in non-small cell lung cancer: stage 1A and B, stage 2A and B, stage 3A and B, and stage 4. And there are various treatment options. Those can include surgery alone, radiation therapy, or systemic therapy, including chemotherapy with both either IV or intravenous drugs or oral medications, targeted therapy, as well as immunotherapy. If your cancer has not spread to other tissues, your doctor may recommend surgery to remove the tumor as a first option. The following surgical procedures are used to treat lung cancer, and they include either a wedge or segmental resection, which means removal of a small part of the lung, a lobectomy, which removes the entire section or a lobe of the lung, and a pneumonectomy, which is removal of an entire lung. Radiation therapy. Radiation therapy is the use of high-energy rays to kill cancer cells. Radiation works by damaging the genetic material in the cells. After radiation treatment ends, cancer cells will keep dying for days or even months. For some people with cancer, radiation therapy is all that is needed. And for others, radiation is given before, during, or after chemotherapy, targeted therapy, or surgery. Cancer for non-small cell lung cancer treatment includes the following. Most commonly used chemotherapy for non-small cell lung cancer includes a drug called cisplatin, which is a platinum metal, or carboplatin, which is its relative, docetaxel, gemcitabine, nanoparticle albumin-bound paclitaxel, otherwise known as Abraxane, paclitaxel, known as Taxol, premetaxate, which is only used as an agent for non-squamous cell non-small cell lung cancer, otherwise known as Alimta, and vinorelbine, otherwise known as navalbine. All of these agents are intravenous therapeutic agents. When testing a pathological sample for non-small cell lung cancer, biomarker testing and target therapies are needed. Biomarker testing can provide information about the cancer that helps determine if a targeted therapy is a treatment option. Testing is done in lung cancer for the following biomarkers, amongst others: EGFR, epidermal growth factor receptor mutation; ALK, anaplastic lymphoma kinase gene rearrangement; ROS1 gene rearrangement; and KRAS mutation. Targeted cancer therapies work by interfering with specific molecules or molecular targets involved in tumor growth and progression. As a result, these drugs can block the growth and spread of cancer. There are various targeted therapies for non-small cell lung cancer. Cyramza, erlotinib, afatinib, crizotinib, ceritinib, osimertinib, alectinib, and bevacizumab. Some of these medications are oral and others are intravenous. Immunotherapy for non-small cell lung cancer. This is the rave of the last few years in cancer in general, and specifically in non-small cell lung cancer. 3 new agents have been FDA approved for this purpose. Immunotherapy is a type of treatment that uses the immune system to treat cancer and other diseases. These therapies enhance the ability of the immune system to detect the presence of cancer cells, identify them as abnormal, and specifically attack them. Nivolumab, or Opdivo, was approved to treat people with metastatic squamous cell non-small cell lung cancer who no longer respond after chemotherapy. Pertuzumab, or Keytruda, was approved in 2005 to treat patients with metastatic non-small cell lung cancer who express PD-L1 and those who no longer respond after first-line chemotherapy. In 2016, it was FDA approved as a front-line agent to treat patients with metastatic non-small cell lung cancer who express high levels of PD-L1 greater than or equal to 50%. Small cell lung cancer treatment options. In terms of stage, we usually stage this a little differently than non-small cell lung cancer. These are staged as limited stage, as is the cancer is in one lung and may be within the surrounding area on the same side of the chest. It can be confined to a radiation field or portal. Extensive stage small cell lung cancer is when the cancer has spread outside the lung to the surrounding areas and to the other areas of the body. Treatment options. Surgery may be used. However, this type of lung cancer is usually found in both lungs, so surgery alone is not often used. Chemotherapy is the most common way we treat small cell lung cancer. Chemotherapy agents that are commonly used include cisplatin, carboplatin, etoposide, irinotecan, topotecan. Additional agents that are also used include gemcitabine, paclitaxel, docetaxel, and ifosfamide. Radiation therapy is also used sometimes in conjunction with chemotherapy to treat small cell lung cancer. Laser therapy uses a laser beam to kill the cancer cells. Clinical trials. Clinical trials study the promising new treatments that are available. All the drugs that are available today and approved by the FDA have gone through rigorous clinical trials. Every lung cancer treatment regimen that is now standard was developed through this clinical trial program. There are various phases of clinical trials, including early phase, which is phase 1, and more advanced phases, which are phase 3 clinical trials. Participants are not guinea pigs. All received either the standard of care or the new treatment with known benefits and risks. Not everyone is eligible for clinical trials, but it is worth asking your doctor about the option of whether you are or not eligible for a trial. What all patients and clinicians should know about clinical trials. Carefully conducted protocols mandate IRB approval, intensive monitoring, and close follow-up. Informed consent is required. Alternative options must be discussed. You cannot be coerced. Total accrual is limited. Statisticians oversee the results and the analysis. Serious adverse events, known as AEs, are reported to the IRB. Excessive AEs can result in a trial's early closure or major amendments. All clinical trials are subject to an FDA audit. Enrollees on clinical trials do as well, if not better, than patients treated off protocol or empirically, and the costs are less than 10% higher than standard care. You are not a guinea pig. You can opt out of a clinical trial at will, at any time without compromise to subsequent care. Your doctor may halt your participation if you are not benefiting, if superior therapies emerge, or if toxicity proves intolerable. And I want to thank you for allowing me to present that information.
Thank you, Dr. Cohen. Now, Dr. Sullivan will share with us her expertise in addressing the challenges associated with a lung cancer diagnosis.
Thank you, Claire, and thank you, Dr. Cohen. And Dr. Cohen's presentation did say a lot about what the lung cancer treatments are and some hopeful new therapies. And I'm going to talk about living with lung cancer. That's both for the person diagnosed with cancer and for the support people who love them. So I'll start talking about some of the potentially distressing side effects of lung cancer treatment. Not everyone will have the side effects, which include nausea and vomiting, loss of appetite, peripheral neuropathy, infections, hair loss, some of the common side effects. But if you do have any of those, know that there's lots of excellent information about side effects and side effects management on reputable websites, such as the Cancer Support Community website, the American Cancer Society website, and another very good website that gives lots of information is cancer.net. In addition, though, it's important to talk with your healthcare team about your particular side effects. Some of the most common and challenging side effects with lung cancer in particular include breathing problems, fatigue, and pain. So I'm going to get into a little bit more detail about why it would be important, if you are experiencing these symptoms, to talk with your healthcare team. Breathing problems such as shortness of breath or trouble taking a deep breath may have multiple causes. So it could be due to fluid around the lungs, or lung infections with lung cancers are common, such as pneumonia, could be due to anemia. And when people can't get a breath, it can be very anxiety-producing and distressing. So how each of these conditions will be treated and managed depends on what's causing the breathing difficulty. So very important to talk with your healthcare team about that. Similarly, with fatigue can have multiple causes. It could be because of anemia. There could be hormonal changes. Fatigue can be caused because of pain or anxiety and depression. So again, the treatments may range from medication for hormonal changes or anemia to light exercise for depression. According to the American Cancer Society, 80 to 90% of people undergoing chemotherapy or radiation will have fatigue. So probably having some fatigue is a relative expectation while you're going through cancer treatment. But again, those symptoms can be managed when you talk to your healthcare team. Another significant and distressing side effect can be pain, and pain also can have various causes. The cancer itself can cause pain, or treatment from chemotherapy can cause neuropathy pain, which is nerve damage. Coughing can cause strain and pain on the muscles. So since there are multiple ways to manage pain, it's going to be dependent upon what's causing it. So it might be medications or it might be relaxation techniques. Unmanaged pain can contribute to many other challenging side effects, including fatigue, anxiety and depression, sleep disturbances. So with all of these pain, fatigue, and breathing problems, it could have individual causes. And again, very important to talk with your healthcare team about how to get relief for your symptoms. The emotional impact of living with lung cancer can be significant and managed as well, and I'm going to address that in a little bit more detail further on. So one excellent resource for managing the symptom of cancers and its treatment is palliative care. So while oncology care focuses on the treatment and management of lung cancer, what Dr. Cohen talked about, palliative care focuses on quality of life, symptom relief, and coping with a serious illness. And it can be appropriate at any point in time in treatment. So there have been some very well-designed studies that have actually shown that early palliative care for patients with metastatic lung cancer significantly improves quality of life and mood, and compared with patients receiving standard care alone, they have longer survival rates. So palliative care can be provided along with active oncology treatment, which is different than hospice care. And hospice care is available when potentially life-prolonging treatment has stopped. But it also is a great resource and focuses on quality of life, comfort, and coping with end of life. So paying attention to quality of life is very important because living with a lung cancer diagnosis is challenging. For many people, at some point along the cancer continuum, so that could be at diagnosis, could be during treatment, could be through the end of treatment and into survivorship, or at the end of life, they experience some of these universal challenges: loss of hope, loss of control, living with uncertainty, and unwanted aloneness. So many of the programs at the Cancer Support Community affiliates and at other oncology centers address these challenges. So I'm going to just say a little bit about how that can be done. With loss of hope, it's important to create a space and to be intentional about finding things to hope for. And this may change over the course of time. So a realistic hope can include hope for a cure. And when a cure isn't possible, perhaps hoping for peace of mind or connection to loved ones, or hoping to see some of life's milestones, so graduations, weddings, or a trip to the Grand Canyon. But finding hope and looking for hope. With loss of control, I think we come to recognize that we don't have control over everything, but we can look for what can be controlled. So members of my support group often talk about the challenge of waiting for scans or testing results and how hard it is not to know or not to have control over what those results will be. But they can control following through with their treatment plan, taking care of themselves as best as possible, and living in the present, choosing what to focus on, who to be with, how to spend time. In fact, one of my group members often says when she's waiting for test results, she tries not to borrow trouble. And in other words, she tries not to think about all the what-ifs that the future may hold. When she knows she's done everything that she can possibly do with her treatment and to be as healthy as possible, she kind of not borrowing trouble brings her peace of mind and feelings of being able to control what is controlled under the circumstances. Living with uncertainty can also be very challenging, and I think we all often think about living with uncertainty as kind of waiting for the other shoe to drop, or living with uncertainty in terms of bad news. But again, when we talk about in support groups, oftentimes members will talk about being open to the uncertainty of good things happening. So finding ways to broaden focus from just treatment and cancer out into life and what good things may be in store in the future. So meeting new people, being inspired by others, And I think people are often surprised about the connection the important and significant connections that have been forged in the midst of the cancer experience. Another challenge is that of unwanted aloneness or feeling isolated. And it's very difficult, and often it's going to take some attention to find those people that can be with you, that you can be with. And sometimes that's going to be family or friends. Sometimes it might be professionals, or maybe people going through cancer as well. And oftentimes it's a combination of all of these. So the vision of the cancer support community is that no one faces cancer alone. And cancer can be very isolating, so finding those people that can help you feel less alone is really important. People diagnosed with lung cancer may also experience another challenge, which is a stigma or insensitivity around smoking status in the past or present. So obviously, if you are smoking, it's helpful to stop. And the American Lung Association has a wonderful website, and it's got a phone number, an 800 number, 1-800-586-4872, that can help you stop smoking. But most important is most helpful is just to start where you are right now and move forward, to use your energy and time to get as healthy as possible, both in body, mind, and spirit. So the emotional impact of lung cancer can vary greatly depending upon many factors. So that can include the extent of the lung cancer disease, its treatment. It can depend on each person's personal life circumstances, other stressors that might be happening in their lives, and then personality. So while many people experience some distress, it's really not a one-size-fits-all. And it can impact different parts of our lives and our living and our beings. So it can impact, distress can impact our ways of thinking, our ways of behaving or actions. It can impact feelings and social and spiritual life. But it's important to know with distress when it's time to seek professional help. And so some of the symptoms of a diagnosable depression and anxiety are listed here and include depressed or irritable mood, lack of pleasure in activities, appetite changes, sleep disturbances, fatigue, difficulty concentrating, restlessness, and suicidal thoughts. So it's really important, if you have some of those symptoms, to pay attention to the chronicity of the symptoms, how often they're happening, and the severity of the symptoms. And you'll note that some of these symptoms, such as appetite changes, sleep disturbances, fatigue, difficulty concentrating, they really can overlap with the side effects of chemotherapy or radiation or surgery. So those are not as dependable necessarily in targeting whether or not there's a depression or anxiety that needs to be treated by professionals. So what you really want to pay attention to, I think, in terms of looking for depression or a diagnosable depression or anxiety is a chronic depressed or irritable mood or lack of pleasure in activities, and that happening 3, 4, 5 days in a row. Many people diagnosed with lung cancer are still interested in the activities in their lives. They just might be too tired to carry them out. But if people are not looking forward to anything or not feeling any pleasure in activities, then that suggests that they may have a diagnosable depression or anxiety, and it would be really important to talk to a professional about that. And also suicidal thoughts, that's an example of a severe symptom. And that is really uncommon, and so it would be really important to talk to your medical team if you're experiencing or a loved one is experiencing any suicidal thoughts. In fact, so just to get a sense of how many people would need to go to get psychological or psychiatric treatment, about 20 to 25% of people with a lung cancer diagnosis or with a cancer diagnosis have comorbid diagnosable depression or anxiety. And it would be important to talk with your healthcare team and then maybe get a referral to see a psychiatrist or a psychologist or social worker to appropriately treat the depression. But that means that 75% of people will experience distress at some point along the continuum, but may not have a diagnosable co-occurring mental health disorder. I think as we talk about identifying distress and depression, it's also important just to pay attention to optimism and hope. Lung cancer is challenging, but to have a goal of people living as well as possible for as long as possible is really important, and this is going to look different for different people. So I'll just give an example of how that may occur for some people. I had a wonderful man in my group, in a support group of mine named George, for over 2 years, and the whole time he was living with a metastatic lung cancer. And George had a wonderful sense of humor, as did many of the other people in the support group at that time. And so one night, the group got on the topic of juicing. And one of the women said with a smile on her face, well, after group, I'm going to go to the store and get Naked. And so for those of you who don't know, Naked is a brand of juice. And without skipping a beat, George just turns to her and said, well, where do you shop at? And the group got a big laugh, and they were both laughing. And at the time, George was in hospice. But I think it's a really good example of somebody who can continue to find pleasure and joy and connection in life. And we all know that connection with others is vital in good times and in hard times. So there's lots of ways to reach out for support. Through support groups, as I talked about, finding good mental health professionals that you really connect with, family and friends, clergy, and then just engaging in activities, stress-reducing activities. I think one of the challenges that people often report when they are distressed is that they don't feel like doing these things. They don't feel like calling a friend, or they don't feel like going to a support group. And, but when people do that, so when people don't feel like coming to group but they come, they often feel better once they leave and are really happy that they did so. So I think acting on a goal to get to a group, to go for a walk, to call a friend, versus how you're feeling in that present moment is a good place to start, and a good way to take care of yourself and reach out for help and connect with others. So other ways to take good care of yourself include, taking care of what you put in your mouth, nutrition, which sometimes can be challenging when going through cancer treatments, exercise, even just doing a little bit of exercise, walking out to the mailbox, and then some people, I've got someone right now with lung cancer in my group who's in treatment who kind of not on the days of treatment, but maybe a couple days later can actually walk up to 1 or 2 miles. So when he can, he does that. Trying to get good sleep, paying attention again to your support systems, pampering yourself, having a spiritual practice, and processing your emotions. Well, I will say that a lot of people talk about distraction and keeping busy, especially at high times of distress, and I think that is extremely helpful. And also, it's important to find practices or activities that calm and relax. Not just distract, but actually calm and relax, and continue to do those on a regular basis So this could be a relaxation class, it could be a yoga class, it could be a meditation class, prayer, music, calming music, visual arts, just finding ways for calming the body and calming the mind that work for you. So tips for caregivers. I hope that, in my part of the presentation that I've highlighted that it's really important for primary support people to take care of themselves as well, and that they also may feel distress. It's really hard to watch a loved one suffering, and there is some suffering with lung cancer at times, and I think support people can suffer as well. They're actually at an increased risk for depression and anxiety themselves. So really practicing good self-care for the support person is important as well, and we encourage that all the time at the Cancer Support Community and provide programs for support people. So this is a wonderful quote from Terry, who is living with lung cancer, and she says, "I'd say as a person who was raised to be independent that I wasn't accustomed to leaning on anyone. With cancer, you have to let go. You have to rely on the strength and love of other people." And that certainly seems very relevant for most people. So we've got a list of terrific resources here with the American Cancer Society, the Cancer Support Community, the American Lung Association, Lung Cancer Alliance, the National Cancer Institute, the Patient Advocate Foundation, and the Cancer Legal Resource Center. And I would also add on there cancer.net, which is a wonderful resource as well. And then the Cancer Support Community website has a lot more information on small cell lung cancer, non-small cell lung cancer, immunotherapy, clinical trials, and making informed treatment decisions, some of the things that Dr. Cohen talked about. And I think that is it for me, so thank you.
Thank you, Dr. Sullivan. We would now like to open the discussion up to the audience. We may have answered some of your questions during the presentation. However, if you have any additional questions, please feel free to type them in the question and answer box to the right of your screen. So our first question I'm going to ask Dr. Cohen. There are some new treatments available for lung cancer, and some of the newest treatments are available in immunotherapy. I have a specific question about immunotherapy, but before I get to that one, can you just talk briefly about what some of the side effects of immunotherapy are? Because I think a lot of our audience has an idea what the side effects of chemotherapy are, but no idea what the side effects of immunotherapy might be.
Sure, Claire. So immunotherapies are in the stage of what we call PD-1 or PD-L1 therapies. And primarily, immunotherapies work by, I would say, sprucing up your immune system. So they cause various effects on your body, including pneumonitis, which is inflammation in the lungs, hepatitis, which is inflammation in the liver, nephritis, which is inflammation of the kidneys, colitis, which is inflammation of the colon, and they also can cause various endocrinopathies or endocrine abnormalities, including thyroid issues, adrenal issues, pituitary issues, as well as skin issues, i.e. Itching in the skin. So by waking up the immune system, you don't have the typical side effects that a chemotherapeutic agent would have, which usually we associate with hair loss, nausea, vomiting, fatigue. You have a different spectrum of side effects that affect certain parts of the bodies on an immune level, most of which can be handled either by steroids or by other manipulations of the therapeutic agents.
Thank you, Dr. Cohen. So now for the specific question, this patient is on Opdivo, an immunotherapy, and they've been on it since the beginning of the year, so for almost a year. This person says that they're doing great, but lately they haven't been feeling as well as a few weeks ago. They have a lot of body aches and some other issues. Is there a reason why they might be getting side effects now, almost 12 months into getting this drug?
So obviously I'm not clear of all the circumstances of where the disease is, but with immunotherapies, one always has to look into the adrenal, pituitary issues and thyroid issues. So a lot of what we call endocrinopathies or endocrine abnormalities can occur, and the spectrum of them occurring usually is between 1 and 11 months, meaning so they can really occur at any point during your therapy. And that would be my first thought into why someone is having some muscle aches. Although you could have muscle aches from the therapy itself that could be somewhat cumulative over time. And I am happy that you're doing well up to this point. I have patients also who have been on nivolumab or Keytruda for now well over a year, and they do get some side effects as time goes along. Fatigue is clearly one of them, and there can be a cumulative dose-associated effect with these agents over time. So I would look into both the endocrine issues, and your oncologist could address those, but also the drug itself can be having some cumulative side effects over time.
Great. Another class of drugs that are relatively new for lung cancer are the targeted therapies that you talked about earlier in your discussion, Dr. Cohen. Can you talk about the latest drugs to treat lung cancer that are targeted therapies and why kind of that alphabet soup of different mutations that patients are being tested for now is needed? So the question is actually from somebody with the ALK mutation, but why do you test for these particular mutations, and how do targeted therapies work for them?
Sure. So that's about a 3-hour lecture. I'll only take an hour to answer the question. First of all, these therapies, if you look at the pie of all the genetic drivers of lung cancer, we're starting to chip away at what drives some patients who have some lung cancers. For instance, there's EGFR mutation, which is epidermal growth factor receptor. And the frontline therapy that we use are actually 2 drugs that are FDA approved for EGFR mutations. And now there's a second drug that's approved if someone should be on those drugs that induce a second mutation called TDN90. So that makes up about, statistically, 5% of lung cancer patients who have those mutations. Then there are the ALK or the ALK receptors or the ROS1 receptors, which make up another couple of percentage of patients who have those mutations. So as you see, we get 5% here, 5% there. We are starting to chip away at some of the genetics of these diseases. And the reason why it's so important to test for these mutations is that the therapeutic agents that are available right now are much easier to take. They come in oral form on some of these targeted drugs. And the side effects are typically substantially less than what we would classify as the cytotoxic chemotherapies. As I discussed during my presentations, those drugs that come in the intravenous forms, we still need those, and we still use those, and they still have efficacy. But the drugs that I'm referring to in the ALK classification are usually crizatinib, which is a frontline therapy for alkaline-positive disease, as well as ceritinib and alectinib, which are the second-line agents that are now FDA approved for this purpose. And there is a huge difference in the frontline drug, and as we move forward in our clinical research, ceritinib essentially has a 20% more potency than crizatinib. And even those who have failed crizatinib, which is a frontline therapy, about 56% still have a response in patients who have prior failure to that first-line drug. So even if they fail a frontline drug, there is still hope that they, even though they have a mutation, could still respond to a second-line ALK inhibitor. In addition, there's a drug called alectinib, which is also FDA approved for second-line therapy, and this has actually been shown in literature to have very good activity in patients with CNS or brain metastases if you should have that mutation. And once again, those patients have a response rate in the 50% range for those who have prior ALK1 failures. And then there are two other drugs in trial. One is called brigatinib and lorlatinib, both of which are not FDA approved at this point, but lorlatinib actually has efficacy in third-line therapy in those who failed second-line therapy of ALK therapy. So we have now multiple lines of single genetic mutations that can help patients. As I said, there's also the EGFR mutation, and there are additional mutations that are being researched to see if we can sort of fine-tune our therapies to a targeted agent rather than giving systemic chemotherapy and cytotoxic chemotherapy that have many more side effects.
Thank you, Dr. Cohen. That was really helpful. We have actually come to the end of our list of questions at the moment. Dr. Sullivan, was there anything from your point of view in terms of coping with the challenges of lung cancer that you want to make sure that we reiterate before it's time for us to end this webinar?
Well, I just think what Dr. Cohen just said is always really important for people to keep in mind, that there are new treatments coming and that the treatments that are coming are less toxic for people, so that people really are living, even with metastatic disease, much longer and much better. So I think there's lots to be hopeful for. And I guess that would be what I would end on.
Great. I think that's a fantastic note to end on. So I want to first I want to let you know about our lung cancer fact sheet, which is a brand new piece that is available for download at www.cancersupportcommunity.org/lungFS. It really is what are the main things you need to know about lung cancer. And I would also like to thank our wonderful panelists, Dr. Seth Cohen and Dr. Debra Sullivan, for contributing their time and sharing this important information with us. Cancer Support Community would also like to thank our program supporter, Lilly. Please take a moment to complete our webinar evaluation survey, which you will be automatically redirected to. We greatly appreciate any feedback you may have. Thanks for your participation, and have a great weekend.